Good afternoon. My name is Francisco Teixeira Barbosa. I'm an oral implantologist based in Barcelona. This is my first webinar for Dental XP. I would like to say thank you very much to Maurice Salama and to Eri Salama to give me this opportunity to participate in this fantastic webpage where we see a lot of webinars and a lot of clinical cases and webinars that are great. So today I'm going to talk about digital protocols applied to oral implantology, and we are going to see the digital issues that we can use daily in our clinical practice, and how these digital protocols are improving day by day. And nowadays we can do a lot of treatments that we couldn't do some years ago. Today it's possible to go with completely digital protocols in oral implantology. And also we are going to see some science that we can digitalize. So we are going to see some clinical cases where some analogical protocols are applied in a digital pathway. So I'm going to start to introduce my lab technician, that is Daniel Carmona. He's a fantastic person, fantastic professional, and he really helps me when I start using digital protocols and all the CAD/CAM and all digital impressions. So he's really a nice person, and he's always there to help me. So I have to say thank you to him also, because he's a very important person in my daily practice. So I'd like to introduce a case that show us how we used to work some years ago, and how things were done in an analogical way. So to start, I'm going to introduce this clinical case where you can see a vertical fracture of a premolar. Of course, we speak with the patient, and when we tell her that to replace these teeth, we can immediately replace the root with an implant. And if the surgery goes okay, and if we can get enough primary stability, we can try to do an immediate loading or immediate restoration. So that's what we proposed to the patient. She accepted. We go with the surgery. Of course, there is something that has to be always present, that biology is the same although the years are passing by. So if you are placing an implant, you have to place it in a correct 3D position, because this is very important if you want to achieve a predictable and aesthetic result. So as you can see, you are going to maintain the space between the teeth, the adjacent teeth, 1.5 millimeters to 2 millimeters. If you go to the articles from Tarno or Castaldo 2004, you know that you have the comfort zone where you have to place your implant, and this distance must be 1.5 millimeters to 2 millimeters from the adjacent teeth, and in the buccal distance you should go 1-2 millimeters palatal to the adjacent teeth. So after drilling, we also check where is the shoulder of the implant. That should be 3 millimeters from the gingival margin. This is what the article says, what the literature says, and what is described if you want to achieve a aesthetic result. Here you can see that we are proving, and we check that the implant is okay, the position is correct. If we are talking about immediate restoration or immediate loading, we have to talk about primary stability. That is a very important issue. If you don't have primary stability, if you don't get enough primary stability, you should avoid to go with immediate loading or immediate restoration. And this is described in the literature. You can use the torque to know if you can go with immediate loading, or you can use an hostel to know what is the ESQ of your implant, and if it is above 660, you know that you can go with immediate loading. In this case, we had an ESQ of 71, so it was okay to go with an immediate restoration. Always, when I do an immediate restoration in my dental office, I don't like to do it immediately in my dental office. I prefer to take an impression, to send it to the lab, and the lab designs me the provisional restoration. That's how I prefer to do it, because it's more accurate, and the details of the provisional are improved if you do it in the lab than in the dental office. So I took the impression, I sent it to the lab, they did the cast, and after that they sent me a provisional restoration. As you can see, we changed the emergency profile, we adapted to our emergency profile, and then we placed this provisional. Some hours, this was more or less 24 hours after the surgery, and you can see there is a good looking of the soft tissue, and the aesthetics is a good result, and the patient was happy with this result. So if you remember comfort zones, you have to respect that. You have to maintain the implant 1.5 to 2 millimeters for the adjusted teeth, and of course in a apical coronal situation should be 3 millimeters below that gingival margin. Okay, this was some months after, more or less 4 months after. We could see that the soft tissue looks very good, and we go with the definitive prosthesis. Here we can see the emergency profile. It looks very good, it looks nice, and we decide to go with a definitive prosthesis. How we did the impressions on that time, when we didn't have the digital impressions, we had to transfer that emergency profile from the provisional to the lab. So we should transfer the emergency profile created with the provisional should be the same that you will have with your customized abutment. So what we do is to place a cap in the implant. We place some silicone. This is a protocol that was published. Various authors published this protocol. One of them, Iñaki Gamborena. And then you get your provisional, you submerge your provisional in a silicone with an analog. You prepare your transfer, the impression abutment. As you can see, when you remove the provisional, your emergency profile is positivated in the silicone, and after that you place your abutment, your impression abutment, and with Duralay you fill that space. Of course, you will get a customized impression abutment that after that you place in the mouth and you take your impression, and with that you can transfer your emergency profile to the lab. Okay, the lab then designs and sends you your customized abutment. This is not a customized abutment. This is a mistake. This is not only a mistake from the lab. This is my mistake because the communication was not good enough, and I couldn't explain well to the lab what I want. Of course, what I mean when you want to do a customized abutment should be something like this. This is a well-designed customized abutment. If you are going to cement, if you go to the articles, to the literature, you see like the article from Lenkevicius that if you have the margin of your abutment far away in the gingiva, it will be very difficult to clean all the cement. So the preparation should be 1 millimeter or use the gingival just to be sure to clean all the cement. It's a very important issue, the leftover cement, to not left any cement, because it you can get some problems if you leave the cement. So after that we cement our definitive prosthesis, and the result was not, for me it was not good enough. I didn't like the ceramics, but the patient was okay and she was feeling happy, and that was enough. Then we go with other gaps, with other edentulous spaces that she had, and we finish with the patient. Of course, we talk about digital. We are talking about digital. As you could see, the only thing that was digital here, it was the customized abutment. That was a CAD/CAM abutment that I started working with more or less 4 years ago, and since then I'm working with this kind of abutments. I feel very comfortable. I'm very confident with them. But it was only the digital part that we could have in our treatments. Right now there are a lot of intraoral scanners that are being introduced in the market. These are some from Lava, you have from the Trios, you have the CEREC, a lot of them. All the scanners they are suffering a lot of improvements year by year. So when you are using an intraoral scanner, 1 year later there is a lot of improvements in your scanner, and you have to buy another scanner or to try another scanner, and you see that is improving very, very fast. Right now I'm using the Trios. This is a Trios that is a pod. Is a portable intraoral scanner, and then afterwards we are going to see how it works. Okay, let's talk about some digital protocols. I would like to introduce my first patient. This is a patient that came to my office. He was not feeling very happy with this fixed prosthesis. This prosthesis was being debonded every week, and the patient was very uncomfortable because it was debonded, and the aesthetic, it was not okay. He was not feeling very, very comfortable with the aesthetics of this fixed prosthesis. So he wanted a definitive solution. If you can see in the X-rays, the remaining roots, they are not very well. They were with a horizontal fracture beneath the gingiva. So I give him a treatment plan. When I say this, we can plan your surgery. We can do the impressions the day of the surgery. You can do immediate implants, and 72 hours after, I can replace your teeth with a provisional prosthesis that will be designed and manufactured with the CAD/CAM technology. I will use a PMEA. After, I'm going to explain why I use PMEA. And after that, we are going to manage the imaging profiles till we have the definitive prosthesis. We did definitive impressions, and we are going to do a definitive impressions with the intraoral scanner with a digital protocol. Okay, let's see some parts of the surgery. This is not a very difficult surgery. Immediate implants is if you have In this case, it is a thick biotype. That's why I encourage me to go with these immediate implants. You are going to see that afterwards I'm going to show some cases where I prefer to do a ridge preservation or socket preservation and then go with the implants. In this case, it was a thick biotype. Of course, the extraction they have to be always atraumatic. This is very important issue, because if you want to maintain the bone and the soft tissue, you have to do it automatically. You check that the bone is there, everything is okay. You clean the socket and then you start drilling. This is the start drilling. These videos you can see all the time. They are in YouTube and also in the ebooks that I publish in the iTunes store. After the starting drill that I use water, then I go with a biological drill that I don't use water, and I do it slowly in 125 RPM to collect the bone. This bone, then I mix it with a PRGF and then I place it in the buccal gap. Something that I've been doing, and I feel very comfortable with this kind of drilling, because you can control the drilling more precisely. You can check your drilling that everything is okay, then you keep on drilling. When you're going to do immediate loading or immediate restorations, you want to get a good primary stability, you can drill, but not drill till the last drill. You can only drill one drill before the last drill, so you are going to get more primary stability. In this case, as you can see, I removed the implant that was in the lateral incisor, because I was not feeling very happy with the 3D position, the apical position. It was too apical. I replaced with other implant just to place the shoulder of implant more coronally. You shouldn't place your implant very deep and never very coronal. There is a position 3-4 millimeters from the gingival margin. Then I place intermediate abutments. Then I will explain why I use always intermediate abutments when I do immediate restorations or immediate loading. I place it with a definite torque of 35, and here I do a digital analogical impression. This is the common impression with silicone. Then I send to the lab, and the lab sends me a provisional. Why I use an intermediate abutment? There is an article, very nice article from Amazon in the year 97, where it explains that if you connect and you disconnect the abutment, this was an experiment in dogs. The mucosal barrier was always cut, and the hemisdesmosal connection was interrupted, so you had a lot of recession. To avoid that recession, you can use an intermediate abutment, and you will manage your emergency profile just above your biological width. So that is very important to avoid recession. And if you are managing with aesthetics, that is a very important issue. So here we have the design of your provisional prosthesis, and it was manufactured in PMEMA. I use the PMEMA because it is a material that when it is manufactured under industrial conditions, it doesn't release monomers. This is important because monomers can cause some irritation and can cause some recession in the soft tissue. So that's why I always use the PMEA when I'm going to do provisional restoration. Here we have the first emergency profile. It is not good emergency profile, but we start changing our provisional. We We put some acrylic in the dental office, and as you can see, the emergency profile is start changing. This is how I manage my provisionals. As you can see, I changed the pontic, I changed the distal of the number of the central incisor. Also in the lateral, I can change the contact point because it was lower. I can go up and place this contact point in a more coronal position, because I know from the articles from Tarno that if you have 5 millimeters, you have a high probability of filling with papilla, and if you have 6, there is less probability, but you still have probability of papilla filling of your contact point. In this case, it was more or less 5 millimeters. I decided to push it 1 millimeter coronally. So this was the changes that I did to my provisional. And there's always that black triangles and that papilla doesn't arrive, and you feel very annoying because you want to feel that black triangle. How we can feel this triangle? So let's see some technique. If you leave that black triangle, probably in 3 years is going to be filled. That was what the article from Gent in the year 97 said, that if you left that the peri-implant soft tissue he suffers some regeneration during the next 3 years after delivering the prosthesis. So if you left that, you could get the feeling of the papilla. But I prefer to manage it when I'm with the provisional. So what we can do is to apply the concept of Sue, published by Sue in the year 2010, where you can transform your emergency profile to a concave profile and then to a convex profile. So what you can get with a concave profile is that you will get in the subcritical contour a more volume of soft tissue. Then you push that soft tissue with a convex emergency profile through the side that you want to get more papilla. Let's see. As you can see, with applying this technique, we could get more or less 1 millimeter of papilla. Here is what our black triangle, and after applying the convex emergency profile. This is something that we are going to see later in another case. So as you can see, very easy, and you can get some results. After getting our definitive emergency profiles, and we were feeling happy with our profiles, with the study result, so we decided to prepare for a veneer, the number 12, and to do a gingivectomy with electric bisturi. So we prepared for the definitive impressions. As you can see, this is the abutments, the posts to do the impressions with the trios, with digital impressions. And the impressions that we have to do is, one is the antagonist, of course, as you can see in the left. In the middle, you can see that we can do the emergency profiles. That should be the first impression that you should take when you do a digital impression, the emergency profiles, because when you remove the provisional, it's going to start to collapse. So it's very important to do the first impression, should be the emergency profiles impression, and then you do another impression with the scan bodies. These scan bodies that will is a part that is the impression that will tell to the lab where the implants are and what kind of implants are these. Of course, this was when the definitive prosthesis arrives. The study results looks okay. The patient was happy, There are some changes that I would like to do, but the patient said that this result was okay for him, and this was some of the photos, some of the pictures, and this is the definitive work delivered to the patient. As you can see, we are increasing the digital instruments, digital protocol in our work. We start only with a CAD/CAM customized abutment. Now we are doing digital impression, and we are doing a CAD/CAM provisional with a PMEA material. And right now we are going to improve this digital pathway, and we are going to increase the digital content in our cases. Let's see the next case, where you can see that is a central incisor. When you see a biotype like this, a thin eye scallop biotype, the red lights turns on your head, and you say, "Woof, doing an immediate implant here could be risky." We know that from the literature that is a high probability of more recession if the biotype is thin. We have the last articles from Can, where he shows that he had some problems in the long term with the immediate implants that he did in the articles in the 2001 and 2005 with this protocol, placing immediate implants with a connective tissue graft in the same day. So if we are going to do immediate implants here, for me nowadays I really prefer to do a socket preservation, wrist preservation, wait and do the implant, and after that you can do some graft, soft tissue graft. So in this case I'm going to use a punch technique. You are going to see now the treatment plan that I explained to the patient. So I tell to the patient that it was too risky to do an immediate implant, so I tell him that I would prefer to do a ridge preservation. Then after 4 months I place the implant, then I do a provisional, and then as you will see all this protocol, all this soft tissue management with CAD/CAM prostheses that I will explain later. Extraction. So we do a traumatic extraction, of course. Then I place some bio-os with PRGF. I place a membrane, and I did that technique described from Charles with a punch technique from the palatal, but different from Charles, because Charles he report 50% of necrosis of his punch of the graft, and that was the reason was because he used a 3/0 suture. If you want to go with this kind of technique, because it is a very sensitive technique, you have to use very thin sutures, 6/0, 7/0, but never a 3/0 suture, because you know from the articles from Burkhardt in 2005 that if you use thin macrosurgical or microsurgical protocol, if you use thin or thick sutures, the result will be different. The recovery and angiogenic recovery will be different. If you use small sutures and small needles, you will get a recovery of the blood supply faster than if you use thick and sutures and needles. So you should respect that. This is science, so we should always do a microsurgical approach in this kind of techniques. So the surgery, after the 4 months after the wrist preservation, we go with implant placement, and in this case we did a roll technique just to get some more volume, because we had a Saber class 3 and I would like some more volume, just to be sure that I wouldn't have any problem. Of course, I do biological drilling. I see if my implant is in the ideal 3D position. This video is in YouTube also, and you can see it on my ebooks also that I have published. The implant, it was a very easy surgery. The other way to do it was a soft tissue graft, a connective tissue graft from the palatal, if you would prefer, but it was only a little volume that I would like to establish, so I did this roll technique, that you don't have a second surgery site. So after that, here you can see the technique step by step, the roll technique. It was the modified technique from CHARF. Implant placement, and something that I've been using in my dental office is I don't do a second surgery, two stages surgery. If I place the implant and then left in completely covered, then I don't do another second surgery. I use the removal prosthesis from the patient, and I'm going to apply an acrylic till I get a perforation in the soft tissue, and I get the implant shoulder, and I can remove the screw. Once I remove the screw, I do the digital impression. In this case, again, as you can see, the antagonist, the scan body, the emergency profile that is inexistent in this case because you don't have a provisional, and the occlusion. Okay, and what emergency profile I should ask to the lab? I like straight, curved, convex. What should be my emergency profile? I like straight emergency profile, but I also like curves, like from Monica Bellucci, like you see here. So I'm going to apply the protocol from Sue and respect the critical contour, that is contour that is 1 millimeter beneath the gingival margin, that I'm not going to change, and I'm going to only to change and to manage the subcritical contact, that is all the corridor that I have till the shoulder of the implant. So what I asked to Daniel is to apply this concept to the provisionals. So as you can see here, we have emergency profile. We create a convex profile if you have the papilla that is insufficient, and then you apply a convex emergency profile. So how we do that with digital? How we can do that? If you remember, in the previous case, I had acrylic in my dental office. There's something that we should know, is that the PMEA is a good material that doesn't have monomers releasing, but your acrylic that you use in the dental office may release some monomers and may lead to some recession of your soft tissue. So how I can use only PMEA and manage my emergency profile with only CAD/CAM, with PMEA manufactured with CAD/CAM technology, and how I can apply this protocol from Sue in a digital pathway, how I can do this. So what I asked to Daniel is, please Daniel, design me 3 provisionals. One provisional is the straight provisional with straight emergency profile. The other provisional is a concave provisional with a concave emergency profile, and the last one is a convex. So I don't have to add any material in my dental office. Only remove material, but never add any kind of material. And I will have 3 provisionals. As you can see here, we have the 3 provisionals that I'm going to place in the patient. Here is my plastic cast after the digital impressions, and I'm going to start with my first provisional and to managing my emergency profile. Of course, there are some black triangles that I would like to change. As you can see in the left, there is a black triangle in the mesial, and in the right it changed, and we have a total close of my papilla. Closer view after changing the provisionals and the convex provisional. You press your soft tissue that you gain with the concave provisional. You press it and you push it where you need to fill the papilla. So after that, after having our definitive emergency profile, this is the provisional. This is our emergency profile. We are going to do a digital impression. Of course, as I said before, the first impression when you are doing a digital impression and you have to explain and to give the information to the lab of your emergency profile, you should do the first impression that you should do after removing provisional is the emergency profile impression. Another thing that technology brings to us is the communication. As you could see in the first case, the communication was very bad, so I had a very bad abutment that I have to replace. In this case, you can use the Communicate, that is a tool that really helps you to communicate with the lab. You can see all the time in your devices, in your Mac, in your iPhone, in your iPad, how is your order, and you can give to the lab more information, photos, and then the lab can also place some comments in your work if he has to change something. And this is a very important tool because it's going to improve your communication with the lab. As you can see, here is a definitive cast, and starts designing our abutment based on the photographs, on the pictures that I sent to the lab. You can design the definitive prosthesis. That is going to be a zirconia, and once it is designed, it was sent back to me, and I can say, okay, Daniel, you can send the order to the milling center to do the restoration. So that's what was done. Then I did the test of the abutment at my office, and then the ceramic loading. After that, we place our definitive prosthesis, and you can see the result is for the patient was good, so that was counts, and for me it was acceptable. You can see the pressure is a slight pressure in the first moment, and a good exterior result with almost a full digital pathway. This is the definitive pictures and the definitive photos of the case. Okay, let's talk about the other protocols that we have in oral implantology. Some of them is immediate loading. For immediate loading, I have this case that I prepared. And this was a patient that came to my office. He has a lot of hopeless teeth, and he told me that he wants a definitive solution for him. He doesn't want to live like this. He can't eat. His aesthetics are very bad. He wants a solution that can give to him more happiness, because he's not feeling happy with this smile and with this life. So I made a diagnostic, and I show him a treatment plan. What could be our treatment plan? I tell him, okay, let's see if I can do immediate loading. When I'm going to prepare immediate loading, I like to see the house feed units of the bone where I'm going to place the implants. In this case, the house feed units were okay for immediate loading. Always above 600, 500, 600, it's okay to go with immediate loading. So I explain him, I'm going to remove your teeth, the upper jaw, and I'm going to do in the same day an impression. I'm going to do 72 hours after, I'm going to place you a provisional PMMA CAD-CAM prosthesis, and after some 3-4 months I'm going to place the definitive prosthesis. The patient said okay. I always explain that I have to wait 72 hours to the definitive prosthesis, and sometimes I have a discussion because people doesn't consider immediate loading when you put the teeth 72 hours after. Maybe for some point of view, if you go to the ED Consensus 2004 or the EA Consensus 2006, in the ED Consensus 2004 it was not immediate loading, it was not considered immediate loading. But if you go to some powerful literature review, to the Cochrane review in 2009, you will see that immediate loading is 1 week after the placement of the implants. So you have 1 week to do that immediate loading. You know that it's very important to not handle the implant, to not manipulate the implants after 1 week, because your primary stability is going to decrease, because the bone remodeling starts, and that primary stability, that mechanical stability, you are going to lose that mechanical stability, and that primary stability is going to be substituted by a second stability. This is very well explained in the literature. Some articles from Barwell, you have others from Araceli Boronat, lot of articles. So I placed the implants. This is the surgery. I was planning to use only 8 implants, but I have had some problems in the canine, so I decided to place another implant in the lateral, just to go ahead with the immediate loading. After placing the implants, I place the intermediate abutments, as you can see, and I take the impressions to the abutments. This I already explained before, why I use intermediate abutments, and this is the surgery. Something that is very important if you are not going to use a prosthesis, an hybrid prosthesis where you have a skid that helps you to give you a lip support, you have to create that lip support. And what I use this is a protocol that I use always in the dentalist patients, that my friend Ramon Lorenzo taught me, is using a PRGF with a BIOS and place it in the buccal, and this is going to enhance your lip support, and the patient will feel that his wrinkles will disappear and will not feel older. That's the problem when you do a lot of extractions. This is well explained in the article from Johnson in the year 79, in the article from Linden in the year 2005, in the article from Trop in 2003, where when you remove a lot of teeth, and when you remove the teeth, you know that unavoidable bone loss will happen. So to avoid that, you have to to over contour that bone. And what I do is to place some bios, some biomaterial, PRGF, some membranes, and I'm going to enhance that lip support. This is very important when I do a full ceramic prosthesis. Okay, here you can see the concept, and on the right you see the lip support will be enhanced with a biomaterial. This is what was planned in the left, and what definitely I did, 9 implants instead of 8. So after that, Daniel designs me the provisional, a PMMA provisional. As you can see, all the screw holes are in palatine, so the aesthetics should be okay. And this is the PMMA prosthesis that arrives to Daniel. Then he check it on the lab, and he send it back to me, where I deliver this prosthesis. It fits okay, and as you could see, I do an impression, I send it to the lab, but I have to wait 72 hours for my prosthesis. There is an article published by Tahmakheb where he can do a PMMA prosthesis in CAD/CAM, and place it in the same day of the surgery, but he has to do 2 surgeries. He has to do a first surgery where he placed 3 implants, and then do another CBCT, and then do a planning, and build a prosthesis, and after that he can deliver. Of course, this is a good option, but I think there will be another options in the future where you can do a digital impression in your dental office, and in the same day, with a milling machine in your office, you can get your PMMA prosthesis at the same moment. But this is the future, and something that I am work now, and I hope soon to have some results. This was the result after some months. I start to perform and to improve the emergency profiles with the prosthesis. I had to do some graft because there was some recession. The connective tissue graft I get it from the tuberosity, and after that I'm going to do a digital impression. This was the first digital impression with 9 implants. This was some kind of test, and I did it with the engineers from FIBO. Of course, this was great help from them to do this case, because very difficult case to do with a digital impression, but we did a test. And there are some doubts, and the first doubt is how I can get the occlusion or the bite resistance of this case. Okay, I did all the protocol that you saw before, the antagonist, emergency profile, the scan bodies, but how I can do the occlusion? So I used the provisional, and I cut that provisional, and I place the posterior part of the provisional, I screw it, and that is what is going to give me the vertical dimension. That is what going to positionate the jaws. And once I positionate the jaws, I go and I scan that, and that's what is going to be transferred to the lab as the information to the lab, and this is going to be the occlusion. This is the protocol that I create to do this registration. As you can see, you place the provisional in the posterior teeth, and you do the impressions. After that, the lab builds the model with the model builder. As you can see, 9 implants. I have to be sincere, because when this work arrives to my office, I thought it was not going to work, because we were testing. We tested with 6 implants, 5 implants, but never 9 implants. And after that, it was built the framework. This is the framework. As you can see, a beautiful framework in CAD-CAM. It arrives, and definitely when it came to the office, we did a test and it was okay. It was a fantastic day for me and for all the team, because we were amazed with the result of the framework and the digital impressions. Took a radiography, as you can see, with only one screw. We test, and then we send it back to the lab where the ceramic loading was done. And after that, I place the prosthesis definitively in the patient. As you can see, the result, it was okay for the patient. He feel very happy. Now he has teeth again, and he can now chew again and eat again, because the functions and the aesthetics are reestablished. So for today, I think it's okay. It's all for me. I have to say thank you again to Henry and to Dr. Maurice Salama for this opportunity. I feel very happy to do this webinar. I hope to do it again and to do some more clinical cases for dental XP. It will be a great pleasure for me. This webinar I'm going to translate it to Portuguese and to Spanish. I will do it. It will be better than in English, because I'm not native in English, as you can see, but I'm a native in Spanish and Portuguese. And so if you are Spanish or Portuguese, you can then watch it on Spanish and Portuguese. Of course, you can see some of my works in ebooks that I have published in the iTunes store. You can download it and see them in your iPad or in your iMac. So for me, that's it. Thank you again very much, and you can always send me an email to info@franciscobarbosaimplantology.com. You can check my webpage, www.franciscobarbosaimplantology.com. So a pleasure and good night.